Yes. All right. Welcome back. This is I'm PT Nandi. We're here at SHARC Doc Talk with Dr. Alvin, PT, fellow
Hello.
PT. And we are Sans, Dr. David, and Dr. Connolly because they are out this week. So we got to fill in and do our best. We were just conversing about our week. How was your week, Alvin? Anything interesting and new?
The only new thing patient-wise, excuse me, got a new ACL patient, or a patient with an ACL injury, reconstruction. And so we're going through the first 2 weeks of his we just finished his first 2 weeks. He came to see us. He's a college quarterback. Came to see us every day this week to really try to get back as soon as possible. So he's really going after it and trying really hard to come back as soon as he can. So it's really inspiring to see a high-level athlete, really go after his rehab. Really cool.
Yes, that's always my wonder is sometimes do I feel like I'm a little bit too conservative with some of my athletes. Growing up as an athlete myself, it's been a while since I've been kind of in an athletic realm in the sense of competing in a sport, and have often thought, well, how do I put my patients through the paces that would make them feel like they're on the right track? And so it is nice to see you work with your patient and kind of get him kind of to where he's expressed. I've heard him express his gratitude for where the pace that he's going at. He's like, I feel like I'm really going to get back really early, and I see that in him, and I see that in your treatment. So that's kind of neat.
For sure. And I think a big advantage for him is he's number one, a very high level athlete. He'd already prehabbed quite a bit before the surgery as well, and he kind of knew going in that he may need to have that. So he was already really strong. His range of motion was already really good, and so it makes my job a lot easier. But even still, some of the knee flexion stuff is still really tough, and it can be really painful. And so even though you can prepare as much as you can, you really don't know until after your surgery what are some of the limitations you're going to get, some of the issues that you're going to face, and it's all a really big journey. And he's got a really good head on his shoulders, and he's really positive, and it's really great to see.
Now, did he have any previous surgeries compared to be able to compare his rehab to this surgery?
Not that I know of. This is probably his first major surgery.
Okay. Yeah. I'm always interested. Patients ask me, well, how long do I expect? And we can read the research and we can do the analysis and we can have a stock answer for them. In my experience, I've had my hip replaced and I've had a hernia surgery. My body responded in a certain way, both to each surgery. A little faster than I expected. And so I will always kind of default to, well, how has your body, I'll ask first, have you had surgery before? If you had, how long did it take? What type of surgery was it? The severity? And that generally gives them a good understanding of what we know from our own protocols and experiences about the area. ACLs definitely have a specific timeline, and most orthopedists have their own type of protocol that they like to take their patients through in order to get the best results.
Right, and then there's also the different type of graft that's being utilized.
Correct.
He had a patellar tendon graft, which is generally the standard. There's an increase in popularity for the quad tendon graft, and I've seen several of those, and they tend to recover pretty fast. The range of motion comes back quite a bit faster. The quad strengthening is a little bit slower because it's a quad tendon graft.
Right.
But man, the range of motion comes back really fast, and that's really interesting to see as well. So that's kind of another option for people to do. That seems to be a more geared towards that direction versus like a hamstring graft or an allograft, like a cadaver graft. So that's really cool to see.
The other thing I learned about quad tendon grafts, my daughter had her ACL replaced with a quad tendon. And the doctor who did it really likes it because of the thickness of the quad tendon, makes for a little bit more feeling of reinforcement in the joint, as well as he had to kind of slide the tendon a little bit I think it was anterior of the normal placement of our of our physiological normal tendon.
Oh, so the footprint
was different. He had to move the footprint because of it decreased the risk of cyclops lesion.
That's interesting. I think you mentioned that before.
Yeah.
That's a very
cool.
cool.
And a patient in the practice that I work in elsewhere had her quad tendon done, and she actually ended up having a cyclops lesion.
Oh, wow.
So that was interesting to see, and that gave her some considerable difficulty. She actually had to go back in and have a little bit of a manipulation under anesthesia.
Whoa.
So
how long did it take for her to realize that?
Probably took a good 4 to 5, maybe 6 weeks.
Wow. Yeah.
Because she got to a certain point where she couldn't bend her knee anymore. And it was just like, it was stuck.
Do you remember the range of motion? I was kind of in the details.
I don't. And I want to say she was past 90, but really had a hard time getting past 90.
Okay, so that makes sense.
Yeah, once past 90, she was finding a lot of restriction and difficulty with bending, and it was very painful.
Yeah, so especially after the first couple of weeks, if they're barely getting past 190, that's like a huge red flag, right? So that's good to know. It's good to see, like, hey, like something's going on. If after a certain amount of time, they can barely not even get to 100 yet. Like, okay, maybe it's time. Talk to the surgeon again and see what's going on.
Yeah, they ended up having to do just a very, very minor clean out in a sense. And then I don't think they had to reposition it, but she ended up, and now she's great.
Good.
Yeah, it's really good. So... so that was good. So he's recovering very well and excited about returning.
Yeah, swelling is really good, and range of motion is really good. And so he's going back to school, so I'll probably see him in a couple months, and we'll see where his recovery is at. And so it'll be nice to start to progress him from the early stages to more of a mid-stage to late stage and try to really get him super strong. And I mean, his goal is to literally get jacked. So prior to getting back into playing.
It's always a good goal to be jacked.
Right. How about yourself? I mean,
I had a very interesting, I had a good week. It was, I think, a little bit of a short week because I came off just some time off, which was great. But I have a patient who has plantar fasciitis presentingly, but I'm always curious about if it's actually plantar fasciitis, and most of the time it is. But we were at a spot on, I believe it was Tuesday, where he's about 80% better and still has a little bit of ache. I've been doing some grass and stuff on there, some scraping, and he gets really tender and really sore. But then he was saying something about, well, I was sitting watching my son play volleyball, and then it got really achy when I stood up, and feels better in the mornings. And I was like, let's see. So I checked his range of motion and his lumbar spine, had him do a couple movements, and it made it better. Wow. I had him do some repeated flexion, and that really helped kind of take away the ache. It made the ache
repeated flexion. Nice.
Yeah, it made the he was having some restriction with end range lumbar extension. So then when I had him do repeated lumbar extension, prone press ups, it got worse.
Oh.
Yeah.
Okay. Yeah. So that's why you went to the flexion.
And then I went to reflect. I went to supine flexion, knees to chest, elbow knees to chest, and it got better.
Nice.
And then we did a couple other things, and it got even better.
Wow.
All lumbar related. And so I was like, all right, let's kind of go this way. And sometimes I think that there is maybe some nerve restriction and a little bit of, he definitely did have, like a little bit of posterior tendinitis, posterior tibialis tendinitis, that can sometimes mimic plantar fasciitis, as well as a little bit of some tenderness at the plantar fascia insertion that were definitely classic signs of plantar fasciitis. But then this kind of cleanup at the end, kind of wrapping everything up, the back definitely presented itself. So that was kind of interesting to see.
Is that something you think in the future, when someone presents with something similar like that, would change how you go about your initial evaluation or testing prior?
Definitely. I definitely think. And another colleague of mine, she finds that a lot of her direction in which she treats, she finds from the subjective assessment. I mean, the subjective part of the evaluation. And I think we do that normally, but I think sometimes we're a little caught up in the time element, and we don't necessarily take that extra time to kind of consider those definite peripheral types of irritations that could happen centrally.
Right. I remember I had a mentor or an instructor tell me during the subjective, so meaning during the time when your patient is telling them their story about what's going on, is if you can ask the right questions or ask, quote unquote, good questions, they can really tell you what's happening and where to go about treating them, right? Instead of always thinking like you know best, right? And because we really don't know what they're feeling, but if they give you those hints, like he was saying, like into certain positions, and like that led you to those that clinical reasoning, really allows you to help you guide you towards that treatment program for that person, and allows you to check things off right away, and all of a sudden, like, boom, like you got it going on, versus waiting months later and be like, oh, I didn't check that early on because I didn't ask the right question.
Right.
And I think the key thing is like, how do you ask the right questions, right? Like as a good provider, a good physical therapist, or a chiro, or whatever, is like, can you ask really good questions? I think that's a really good skill to have.
Yeah, and it definitely taught me, one of the things that taught me early in my career was actually listening to your patient. I remember coming home one day after work and thinking, wow, my patients told me a lot of really good things today. And then when I listened and followed a little bit of their direction, in the sense of, well, I feel like I was treating a patient one time with shoulder issues, and they said something about their shoulder, and it led me in a certain direction, and it really made their shoulder better. And it was just a nice kind of aha moment of, yeah, I really think that the patient, obviously they feel what they feel because that's them inside. It's not me. I'm not able to feel what they're feeling. And I think, like you said, that's where getting those really good questions to lead them in a way that gives you the answers that can tell you whether it is exactly coming from that area, or coming from a different area, or something totally unrelated. Because they know how they feel. We don't know. We only know with the questions that we give them.
Right, because in our brain, we're trained to think of, we have a certain diagnosis that we think it's going to be, right? And our goal is to either confirm it or find something that disproves it, and then go from there, right? And so that's where the question, versus me trying to like make the person give me the answers that I want, and then yes, therefore you have that, right? And I think a lot of us, me included, sometimes I'll do that, and it's like, I'm pretty sure it's this, but they're telling me the wrong thing, so tell me the right things. And it's like, and it's not a good way. We have to, like you said, we have to really try to listen to what they're trying to tell us, right? Because they're going to give us these answers, and instead of us always having to have the answers already.
Yeah. And so to wrap up my patient this week, he came back the next visit, which was yesterday, and he was better. He said he went and was a little worse the next day because I'd worked on his back, and that had kind of made him a little sore. But he said everything everything surrounding the treatment for his back helped make his foot better. So that was kind of a neat little
Yeah. So I think you utilize a lot of these information that was given to you, like we were talking about before, what the patient was experiencing, and you use it for your own clinical reasoning, which is what basic school teaches us, is clinical reasoning.
Yeah.
And speaking of clinical reasoning, one of the topics that we want to talk about today is, will artificial intelligence, AI, replace physical therapy? Right? Can they give us that clinical reasoning that we no longer have to do if you just simply type it into ChatGPT?
Right, and that's the thing that I thought about when you started asking that question of, can the computer, with all the information it has, will it be able to differentiate what the patient is, or what the information is being given, and how to lead towards the ruling in or ruling out, like you said? Because that's a lot of what we do, is our differential diagnosis, and making sure that all of the answers that we want take us to the way that confirm what it is we think that the patient is talking about.
Do you think it will replace a physical therapist?
I mean, I could see that somebody, you know, that's like WebMD or, you know, Dr. Google, as most people have said. Right. I don't think that it will ever replace it. I think that it is a good supplement with confirmation of certain things and structure and concrete things that we know to be true, but there's only so much I think that a computer or a piece of technology can do to listen. I think a lot of what my experience has shown me is we also have intuition, and there's a level of intuition that I've followed throughout my career where that little voice inside your head that says, go this way. Think about what that person just said about the way they sat just now versus did they ask me a question about sitting, or did they ask me a question how they would feel about sitting? And I see that that kind of separates us from the technology. And, you know, I think people like the human element. I think they like having somebody listen to them that can empathize. And as much as ChatGPT can be programmed to empathize, I just definitely don't think that it's something that can replace just that human idea of, or that idea of human involvement. I mean, what's your opinion?
No, I agree. I think it definitely won't 100% replace PT. I think it'll supplement it quite a bit, right? We talked earlier prior to doing the podcast about simple things like documentation, right? That's a big thing that you'll see all across any type of healthcare is documentation. Like it's, you know, putting recording into your phone and having ChatGPT spit out the SOAP note, which is huge for healthcare. I mean, documentation is a bane to our, you know, profession.
Absolutely.
You know, and so
yes.
Which is unfortunate. It takes up a lot of unnecessary time that we could be using to treat patients.
Yeah.
I mean, I've tried. You know, one of the things like with at least the current iteration of artificial intelligence is how strong its strength is as strong as its LLM, right? Its large language model, right? Where is this getting its information from, right? And each ChatGPT, Anthropic, all the different ones have their own way of getting sources, right? So a lot of things that we see and when we do, a lot of it's anecdotal too, anecdata, right? Like things that through our experience has helped us allow us to have a certain level of clinical reasoning,
right,
to treat a patient, right? Every patient is so different, right? Everyone's an individual. So how is it that you know, a computer-generated thing take into account individuality of a person?
Yeah,
right?
totally.
And so, like you said, like if your patient has plantar fasciitis and it comes down to it's a lumbar radiculopathy, that's, you know, it makes sense, right? If you're in healthcare, but it also like a patient may not understand that, you know, or and a computer may not get straight to that connection right away. You know, it'll be very focused to the foot. And I've done that before. I've Googled how to treat plantar fasciitis, right? And not Googled. I've used ChatGPT for it. And early on, at least right now, it's still very basic. It's a lot of like your typical things that you would see, you know, roll out the bottom of your foot, you know, maybe the calf, do some heel raises, and that's kind of the extent and the level of it. And that's it. You know, like how do you progress from that to a higher level athlete? Maybe you can ask that too, but it's still very short-sighted, I guess, right? And so especially if it doesn't go away and your symptoms are exactly the same spot, then how do you know what to ask or how to go about going to the next level? And that's where we come in, or at least we have that.
And I think, like you said too, like it's a model that's developed by someone in the sense of it's programmed how to respond in a sense. I think is that if that's what was the LLM, the large language model, right? Yeah. So is that just kind of like the vocabulary that's available to that software? Like most computers, they're all programmed by people, and if they're not programmed a certain way, they're not gonna, like you said, involve or think about. Right.
I
that
do
can
think,
be able to take that step.
I do think it really helps with things like programming. Like if you're going into like, maybe I'm trying to want to build strength for my shoulder as a volleyball player.
Okay.
Like it does a pretty good job with that. It's pretty scary. You know, it does good at periodization, right? Knowing, you know, where you are, how to strength build, hypertrophy, strength training, whatever,
Right.
power, you know, it knows how to do that. And I think it does a good job, at least at a base level,
Right.
you know, broad level way of doing it. I mean, my wife uses it helps use it for her training program for running.
For running, yes,
you know,
that's
like
true.
how many miles, and you can tell it like,
Right.
hey, these are my mileage, these are my goals, or
Right.
like even like, hey, I felt kind of crappy today. What should I do tomorrow?
Right.
And it does a good job of that. And I
That's
think
interesting
really
to hear,
nice.
because it does sound like it in a way a very good supplement for us, in the sense of being able to just utilize the technology to say, hey, design a program for my patient who has shoulder soreness based on my findings of labral tear, right? So something around that model could give you then kind of just automatically generate, instead of having to take the time to write it out yourself or create it yourself. I could see that as a definitely good supplement.
Right. I mean, obviously you don't want it to use it as like a lot of mills, places where typically high volume, they'll have like a sheet, literally like a sheet of exercise for you. You're
Right.
like, knee pain, here's your sheet, you know. And so, you know, hopefully if you're utilizing it, you want to be as specific as possible if you are going to try to utilize
Right,
it.
right. And you don't want your practice to boil down to funneling people in and out just based on kind of giving them a piece of exercise paper or literature to do at home, because that's why you're there, to give them the feedback that they need during the exercise. Right. I mean, that's one of the things I think we strive for here at SHARC, is that we're here for our patients. We're here for an hour. That's our goal. We want to be there every step of the way. We want to be there with every movement, so that even though you feel like you're doing the movement correctly in your mind, if that's not happening and you're still having pain, we are able to see that and be there right there next to you and guide you through that, as well as kind of develop the awareness of how to change that and how to strengthen that change.
Right. Yeah. There's the accountability portion, right? Having someone, like you said, next to you, supporting you, that's a huge part of someone's overall healing, right? There's also the element of touch, right? Like here, we're pretty manual therapy heavy. I wouldn't say it dominates everything. We exercise a huge component of our treatment plan, but we do like to utilize our hands and soft tissue things, you know, cupping, things like that, to kind of help supplement what we're already trying to do with exercise. It helps open up different avenues. It allows us to access, you know, pain points, ranges of motion that sometimes we can't simply get by simply just having them stretch it out or foam roll it out. And so I think that's a really important part that AI can't replace.
Yeah, no, totally.
Right, but we shouldn't be afraid to utilize it in order to help benefit the business and benefit our patients, like I said, help writing programming, strength training programming. I think that's always really good. Documentation is going to be really good. Helping us with clinical reading. Sometimes if you get stumped, I'll ask it like, hey, what do you think about this? And it might trigger some ideas that I wouldn't have thought otherwise.
Like an artificial brainstorm or something that'll kind of spark your thought process to a direction that you might not have thought about, just because you did give it the right information to respond to the question that you had.
Right.
I like that.
Yeah, and so there's so many things that technology can really amplify for our skill set already that we shouldn't be afraid of. And so in that respect, like, I think it's going to be a huge change in how we practice and how it's added to the value that we provide here.
So with that, with the idea of starting to implement things like AI in our practice, you came to SHARC a specific way with Dr. Travis, because you two kind of had a shared thought process of how you wanted to treat and how you wanted your patient population to be treated. Give us a little bit of insight in kind of that process that brought you there, and kind of how you met Dr. Travis, and what your goal is for, you know, your vision here at SHARC.
When I first started with our stem cell regenerative medicine doctor, our specialist, Dr. Goswami in Newport Beach. And he actually asked me to help out and do his evaluations and be a PT in his clinic first. And it was really fun. I really liked that. And then I had met Travis at the same time. They were both sharing the same clinic. And he also needed a physical therapist. And so I was working with a lot of his patients as well. And then as we continued to grow, we needed a bigger space. And so we decided to, Travis and I and Aurora, our massage therapist, decided to move and go into a bigger space in order to, have a giant squat rack, multiple squat racks like we have here, multiple different specialty equipments, things like that, to help our community or a group of patients that we enjoy working with, or very high level active people. And so we needed a bigger space. So we decided to move and open up this space. We were originally like half the size we are now. And as we continued to grow and our next door neighbors moved out, we had an opportunity to grow and build a larger space to have more higher level equipment, a longer space so we can, do a little bit of running, a little bit of sled pulls, things like that. And really, our goal was to provide like a multidisciplinary, like, Dr. Travis is a chiropractor, I'm a physical therapist, or we have a massage therapist here as well, to give our clients, our patients, as much resources as possible in order to allow them to get back to an active lifestyle, right? If they're here and, and if they're a powerlifter, for example, we don't have powerlifting equipment, then this isn't the right place for them. Like, right. How can we get them back to where they want to be? And not only that, like better than where they were before, right? We always like to say, we want to get you better than normal, because normal got you here. So we need to be better. You need to be better than normal.
Right.
And so that was kind of our goal. Our dream is to build a space for multiple providers in all different disciplinaries to help as many people as we can in this area.
Yeah, I know that when I first came to check out your space, a little background on Alvin and me. Alvin was actually, the first time I met Alvin, he was my student when I worked at another physical therapy clinic. And so I've had the opportunity to see him go from learning as a student, multiple years that way, to growing this business. And so, like he said, when they first started here, the wall behind us with the logo was as big as where the clinic ended. And so I came in a couple rooms, met Aurora, and then the next time I came, I think they had already knocked down the wall and and expanded. So it was a great, quickly growing practice with a couple PTs, a couple chiros, and a couple massage therapists. And about a year and a half ago, Alvin reached out to me and said, hey, I have some overflow and would need a physical therapist to take that overflow. Do you know anybody? And I was like, yeah, I know somebody. So I came in and negotiated and just basically sat down and talked to Alvin about what he wanted with kind of my role would be and how I could help. Personally, and I told him, I said, hey, I'm just here to do whatever you need to do in order to take some of the stress off of you, to treat patients in a way, that helps guide your vision to a community-based, interdisciplinary rehabilitation practice. And a place where, we basically want to go and we want to get better in the sense of physically, emotionally, because we're there with people that we like. We're there with people who are like-minded. We're there with other people getting better because they look like athletically or actively they look like me. Right. And I really felt like that was a place that I wanted to be a part of, and not only to be able to give my patients that freedom and that ability to utilize the time with me one-on-one, but of course also to work with Alvin, to work with Dr. T, to work with Dr. Dionson and all the other practitioners that are here in the office. It's been a very great experience. And it's always nice to go to a place where I feel like I'm valued. I feel like my experience is valued, and I feel like that the patients are valuing our effort to guide them back to their, like you said, 100%, but then 100% plus and beyond. So I appreciate Alvin for allowing me to be in this space with him, and to be able to kind of learn from everybody else around us that provides a service here at SHARC. It's been a very good experience for sure.
Oh, I mean, we greatly appreciate that you're here. I mean, it's huge. I always tell people, like, Nani was my number one choice when we were trying to expand here and to get another physical therapist, another provider with his skill set. It's not just about getting just a random person. Like, I needed someone who was experienced, like was going to take on some of our patients that want a certain level and quality of care. And he was the first person I know that can provide that. And not only that, but be different from me, right? Because I don't need another me, right? I want someone who's better than me. I feel like we should always be around people who are better than us, because it helps me grow, right? And Nani has a extensive experience with manual therapy and even exercise. And he's been in the game a lot longer than I have, and so to have that experience in-house and combined with Dr. Travis and Dr. David, it's huge for us and for our patients. And so, I thank you, Nandi.
Yeah,
for
of course.
being
Thank
here,
you.
for sure.
I much appreciate it, for sure.
What
else we got?
A little segment. Let's kind of transition to our last little thing. It's called Overrated, Underrated. I'll list out some stuff that.
And he wouldn't let me look at the question, so I have no idea what's coming. We talked about a couple, but he's like, "No, you got to let me write them so that I can."
These will be interesting. I mean, I'll comment as well and give a little bit of my opinion, but we'll go kind of fast. Give me like one or two sentence, maybe just words.
We'll do it.
Overrated, underrated, Nandi. All right, first one: BFR, blood flow restriction. Overrated, underrated.
I think it's underrated. I had not heard a lot about it, and I was hesitant to use it just because I didn't know. Apparently, it's been around for a while, but I've seen some really good results from it. And I would say the latest is one of my patients who's had just this really chronic underlying labral issue. We did BFR just in his last treatment for we did 5 pounds with bench press, flies, and I think that was it. And he literally he could feel the burn in the muscle, but didn't feel the pain that he was feeling when he was doing his flies. And then he didn't have that same pain after we finished.
Right. It's a cheat code. You can do low. You can do.
I love it.
Low weight exercise, but increase high demand to the musculature.
Yeah.
It's great. All right, next one. Icing. Cold therapy.
I mean, I think it's underrated just because it's nature's anti-inflammatory. Tell me, what do you think? Overrated?
I think it's rated. It has its uses. I think we sometimes overuse it as a way of
I could see that.
Of pain relief. There's a certain point in the injury where ice probably won't do too much other than numbing the area.
Right.
So eventually gonna have to move and heat it up. Okay, next one, good one. Ooh, deadlifting for rehab.
Deadlifting for rehab.
Quick, great. Couple sentences.
Underrated. Again, I think it's stage of rehab, depending on where you're doing it, and just being safe with the patient and making sure that they understand their mechanics.
Yep, underrated for sure. It really gives someone confidence. It's a huge confidence builder when you can lift heavy using a deadlift. Next one, kinesio tape, KT tape, rock tape, that good stuff.
Absolutely underrated.
Oof, underrated.
Jeez. I love tape. They call it the miracle tape. I think it's magical. But I've seen it where I've put it on people. It's made them worse, or it's done nothing. But for the majority of the patients that I use it for, they are astounded. I don't really know what it's doing. They say it helps with swelling. I think there's a definite component to swelling control. They say it facilitates muscle contraction to help with fatigue. It can. Definitely. Do you have to do it proximal to distal? Do you have to do it distal to proximal? Arguments are, how do you know that? How does the tape know which way you're taping it? I don't know. It just works.
I think it's just rated. It's neither up or down. It
I use it a ton, so I'm a little biased.
I think it's great for swelling. Everything else, I think it's kind of hit or miss, and so I'll use it as indicated, but I don't go crazy with KT tape. Bosu ball training.
Rated. I mean, I love it. I use it. I don't think it's the end all be all. I think it's a good supplement. I like the fact that we can say rated versus over or under.
It makes it a little easier. Yeah, Bosu ball is okay. I keep it, in the middle. Next one, isometrics.
Oh,
so isometrics meaning like
I would say underrated for me because I know them principally based on what I learned in school. I've learned a lot more of the efficacy lately in the last probably 2 or 3 years. Just because of kind of their prominence with, I don't even know. I've seen a lot of good stuff with isometrics that have really helped, and specifically with like glute awareness.
Yeah, I think isometric is great. Good for pain relief. Good intro to getting someone back to a certain movement.
Yes.
You don't have to go through full ranges. Isometrics are great. Breath work.
Oh, sorry. Underrated.
Very underrated.
Yeah.
Good to...
I'm a Pilates instructor.
Yeah.
I was raised in yoga. Breath is life.
Yeah, really good to bring your nervous system down.
Absolutely.
Huge.
Absolutely.
Bench pressing, simply as an exercise. Bench pressing. Let's see what David says.
God. We love you, Dave. Overrated.
Same. I'm going to say overrated. All right.
It's a beach muscle.
Yeah. I just think if you do a lot of push-ups, I think that's a great exercise.
Exactly.
Your chest will grow that way too. Unless you're powerlifting or you're trying to build a bigger chest.
Yeah. It's totally definitely, unless you're an offensive lineman or if you play, I don't know. Anyway,
next one, core stabilization training. You don't have to go too deep into this. I know it can be kind of controversial, but core stabilization training.
Well, where's your core?
Where is my core? That's a good question. What is the core? That's another.
That's like a can of worms right there. I'm going to say underrated because again, I come from the Pilates kind of point of view. As long as it involves your transverse and your lats and your glutes, I'm happy with it.
I'm going to say a little overrated. I think anything can be a core exercise.
And that's what I say. I think where's your core, right? And I ask that a lot of my patients. Where do you think of when I say we're going to train your core? And everyone 90% of the time says my abs, and I say, it's your armpits to your knees. So, it includes all that.
Right. I think we should do more rotational stuff.
I agree.
A little bit more functional stuff to add, like oblique work, things like that. I think that's more functional course training because I'm not bearing down all day long. Next one, another modality is cupping, myofascial decompression. Cupping.
I like it. I would say rated. I think it helps some. It helps. Maybe it doesn't help others. I don't know.
I think it's underrated. I'm a little biased. I think one of my professors in school helped popularize that in the U.S. They helped.
Really?
Yeah, they helped educate a lot of the athletic trainers during the one of the Olympics in 2016, Rio. I think it was Rio.
I think so.
And so when all the swimmers had the cupping marks, like that was the year I was in school. And
okay.
What's it called? I think it's a great modality. It's not an end all be all. I think supplementing it with movement and exercise
maybe
is huge.
I think that's where I feel like it's kind of rated. But hey, shout out UCSF.
Yeah. A couple more. Social media for exercise ideas. Utilizing social medias.
I don't know. Whatever. Rated. It's social media. That's all I have to say.
I think it's pretty underrated. I am a content whore. I like the hard part is knowing what is right and wrong. I guess that could be subjective. But
I agree. I think that's the whole thing. You have to be able to, we have degrees. Right. We've been to school. We were taught a certain way.
Right.
We see that.
Right.
I like watching people, and I've learned some things from social media, but anybody can put stuff on social media and tell you that it's a core exercise.
I always tell people everything that I know is on the internet for free.
Yes.
What they teach us is clinical reasoning.
Yes.
And that is what is hard to have on the internet, to teach on the internet.
That, and the thing that really gets me is like the guys are like, oh yeah, send me your email for this free thing, and then, but you got to pay for shipping. And I'm like, come on, dude. Seriously, then it's not free, dude. Whatever.
Right. So I think if you can find some good resource, I think we shouldn't be afraid to use as much of resources as possible. I think it's great for the mind. It's great to expand the toolbox, and that's why I use it a lot. And so,
social media as a resource, or the internet?
Social media.
As an internet.
I think social media,
as
like
a resource.
YouTube. I consider YouTube social media. Instagram social media.
Okay, that's true. Social media. YouTube is, and I look at, when I think social media, I think strictly kind of like Instagram, kind of.
Yeah.
But still. YouTube is right, and I agree. I would agree with that. You can get a little bit more.
Last two. Foam rolling as a warm-up.
Oh, I like that. I would say it's almost underrated. Because I could see you could kind of stimulate the muscles with the foam roller. I don't know. What do you think?
I think it's overrated. I think you should do some sort of
more
muscle activation.
More activation.
Yeah, that'll warm you up a little bit
I guess
better.
That's true. It is a little passive.
It's a little passive. And so I'd rather have something a little bit more active.
Okay.
And so I think you can do that, but I think if you add a little bit more, something more activation, some whatever glute work, I think you'll get more bang from your buck that way.
I get that.
Last one is simply imaging, just getting imaging.
Overrated. I think imaging is necessary at certain times. Like if you think you have a labral tear and you go and get an image and it shows that you have severe arthritis, ding, 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 you're going to need a hip replacement. But you can probably figure out that we don't always diagnose based on an MRI.
Yeah, I agree. I think it's overrated, especially in our field. Like, unless it's like something pretty bad, like, oh man, you suspect a blood clot,
right?
Or you suspect something like a red flag, things like I had a patient before, low back pain, severe, and you end up having like bone cancer, like things like that. You have to really recognize red flags, and that's where the clinical reasoning comes in.
And I agree, right? That's our differential diagnosis, understanding what happens is something better, worse, or the same, never changing.
Right.
Yeah, definitely.
Oh, that's it. That was a good one. I mean,
that was it.
That was kind of
nice.
a lot.
I like that. Though. That was good.
No,
that was good. Rapid fire. I tend to be a little wordy, so that
it's too many words.
I know. Sorry. It's just habit. Blah.
Nani's a teacher, so he likes. That's.
It tends to get a little wordy. I have my best friend always says, "Do you want the engineer's answer or do you want the simple answer?" Right. And I tend to go for the engineer's answer or the PT's answer. Anyway, we thank you so much for tuning in. We are SHARC Doc Talk. I am PT Nandi.
And I'm Dr. Alvin.
Peace out. It's Friday. Nice.